So cognition, just looking at just the Giddens book right now, it's the only part we're going to cover today, will be on chapter 33, and that's going to start on page 320. So if you have that book, you're welcome to follow along. If not, you can make notes on your concept guides that you've all completed, or just a piece of paper. It's really only about 9 or 10 slides. We're not like doing a whole full lecture, okay? But I will get it loaded as soon as I can get some storage ability. So when we talk about cognition or a patient's cognitive abilities, what in general are we referring to? Their understanding, okay? So what else could we be referring to when I say that a patient has like impaired cognition? What's wrong with that patient?
Not orientated?
How they're functioning, they're not oriented. Could that be permanent? Could it be temporary or
Both.
both? Can be temporary or permanent depending on what's going on with the patient. All right. So when we look at cognition, it's a mental action or process of acquiring knowledge and understanding through thought, experiences, and senses. So it's how we think, how we feel, how we understand things, how we comprehend what's going on. Will every individual have the same cognitive abilities? No, because everyone's potential will be different. So everyone won't have the same cognitive abilities. And we're aware of that. If the cognition is impaired, it can be several degrees of impaired, and it can be temporary or permanent depending on what's going on with that patient. So when I think about a temporary change in cognition, we think about that 80-year-old that has a UTI. Does their cognitive status alter when they have a urinary tract infection? Because what happens, what do they start displaying? They may become confused. What else? They may become combative. They want to fight the nurse and stuff at that point. Sometimes that's the first thing we realize that's going on with that patient. Let's say if you have a patient who has taken too much of a drug, like some type of street drug or illicit drug. Could that be a temporary impairment in their cognitive status? Absolutely. Let's say if we have that same patient that has taken that illicit drug, can it lead to a permanent change in their cognitive ability? Right. Some of y'all are already going to mental health facilities. If not, you'll rotate there, and you'll see some patients that have a permanent change in their cognitive ability because of drug abuse. So that could be temporary or permanent, depending on the individual. We know this is influenced by our genetics, our environment, and our experiences. How we think, how we perceive things, how we comprehend things can also be influenced by our culture. So if I was raised in Mississippi compared to California, the way I comprehend actions, mannerisms, facial expressions, it's going to be different. When I stayed in California, I stayed up towards San Francisco, I remember thinking, like, people don't speak. That's a difference for me. Like here, I perceive not speaking as, that was kind of rude. I held the door open for you and you didn't say thank you. But depending on where you were raised at, your perception of that would be different because that's the norm, and no one holds the door open and no one says thank you. No one makes that small talk. So it changes how we perceive things and how we comprehend our environment and what's going on. We know that it's a continuum that can change over time. What phase of our life will we have the greatest influence on our cognition for the lifespan? So what, like whether it was infancy, preschool, adolescence, young adult, middle adult, elder, what phase of life is do we have the greatest influence on our cognitive abilities? Toddler phase. When else?
Because infancy, because that's when your like fine motor skills are developing and stuff like that.
Yep. Infancy, toddlers, all the way through adolescence. That's when we notice the biggest influence on a patient's cognitive ability. And we'll get into learning disabilities and such. But let's say if I have a child who, I have two kids, and one is read to, talked to, communicated with, and then the other one born same day and time, and no one ever nurtures that baby, talks to that baby, reads to them, puts them in front of a TV with Barney playing, even if they were born with the same abilities, will they develop to their max potential? No, because what's going to happen with that baby that never develops or is exposed to any social activities? Will they have the adequate speech and comprehension of speech and things like that? Will their language and vocabulary be where it should be? It won't. So even if they have the potential, if they're not in the right environment and influenced by the correct things, they still won't meet that potential. And like I said, impairment can range from mild to severe, temporary to permanent, depending on the individual and what's going on. So optimal brain function depends on the continuous perfusion of oxygenated and nutrient-rich blood. If our patients go without O2, what is that termed? So if I have a lack of blood supply and oxygen supply to the brain, hypoxia or anoxia, depending on how long it lasts. So let's say if I have someone who has anoxia, they get no O2 supply to the brain, and it's for an extended period of time. Let's say if it was like a near drowning incident. Would I expect that patient's cognitive status to be the same after that incident? It won't, because they've lost that blood supply and that oxygen supply to the brain, so therefore it also influences or impacts. So even if they had an IQ of 160 before that incident, once they go that extended period of time without O2, then it can later impact their cognitive ability. So cognitive impairment can be many different categories. We have delirium, NCDs, cognitive impairment that's not dementia, focal cognitive disorders, intellectual disabilities, and learning disabilities. What is delirium? If I tell you that a patient is delirious, what is that? So a state of disturbed consciousness and altered cognition. Usually temporary. Is it a quick onset or a gradual onset? Usually a pretty rapid onset. It may not be like over the next minute, but over hours or days it usually onsets. So it's a pretty rapid onset. They begin to have a decreased awareness of their environment, may have impaired memory and judgment. And what are some things that could cause that temporary delirium to develop? What are some things our patients could have done or been exposed to that cause them to have that quick change in their cognitive status? UTIs could do it. So overwhelming infections could do it. What else? Drugs. What about alcohol? Depending on the person. You got some people that are happy drinkers, and you got some people that are crazy drinkers. So drugs and alcohol can definitely influence it. What if my patient has the electrolyte imbalance? Could that influence it? Okay. What if my patient develops a fever of 104? Could that alter their cognitive status? Absolutely. So dehydration, electrolyte imbalances, fever, sleep deprivation. Have y'all ever seen anyone work 2 or 3 shifts in a row, 24 hours at a time? You want to talk to that person by the time they're on night 3? Absolutely not, because their thinking's not straight, their thought processes are all over the place, so that also can cause, some changes. Medications. Sometimes the drugs, when we term them drugs, are illicit drugs, but sometimes they're medicines that we give. Sometimes we'll go in and give an IV narcotic, and we'll have patients that begin to have delirium and hallucinations and such. So even the prescription medications can influence a patient's cognitive status. The neurocognitive disorders is just another name for dementia. So a neurocognitive disorder is just another term for dementia. And it's going to be a deterioration of all cognitive functions. So it's a deterioration or decline of all cognitive functions. So when a patient has dementia, is it a quick onset or gradual? It's gradual. Months to years for this to develop. A lot of times the family will look back and say, oh yeah, I remember this time last year when she kept misplacing her car keys, or got out of Walmart, didn't know where she parked at, things like that. So it'll be a gradual onset or a gradual decline. It may be irreversible. It could be primary, secondary, it can be irreversible typically, or it may be due to another disease process. So sometimes patients have dementia and we don't know why it develops, they just begin to have dementia. Other times it may be related to another disease process that they develop, and then the dementia follows that disease process. One of the exemplars that we'll go through next week will be Alzheimer's, and that's a form of dementia. So Alzheimer's is a form of dementia. So it's a deterioration of all cognitive functions. It develops over months to years, so it is a gradual onset. Can be primary or secondary, so it could be that the patient has dementia for no other reason and they developed it, or it could be related to another disease process. So cognitive impairment is not dementia. It's going to be a mild cognitive impairment. And that just means that the patient has had a reduction in cognitive function that happens sooner than expected. So it's a decline in cognitive function that happens sooner than expected. So essentially that would mean that my 50-year-old has the cognitive status of an 80-year-old. So that decline is happening, but it's happening at a rate that's sooner to be expected. So for their age and educational level, they're not having the cognitive status that a textbook would expect that patient to have. If a patient has cognitive impairment that's not dementia or mild cognitive impairment, depending on the patient and how it progresses, it can develop into dementia. So it can develop into a secondary dementia. These patients will have an effect on their memory and thinking, but not their overall day-to-day life. So they physically can still get up and do things, but their way of thinking and their memory to do things will become altered. So if I have a patient that has dementia, those patients lose all cognitive abilities. They forget how to think, how to eat, how to go to the restroom, how to drive, when to sleep, the difference between day and night. All cognitive abilities are affected. If I have cognitive impairment that's not dementia, then those patients' memory is affected, but they still can physically get up. So they remember how to walk, they just don't know where they were going. When you have dementia, at some point they forget how to even get up and walk, okay? So a neurocognitive disorder or dementia is going to be a more severe case. So a cognitive impairment, not dementia, is going to be a mild form, all right? And then the actual dementia that develops would be a more severe case. A focal cognitive disorder just means that it affects a single area. So it just means that it affects a single area. It's not all-inclusive, doesn't affect the entire cognitive ability. It's just one single area. And a lot of times we'll see this in patients that have amnesia. So a lot of times we'll see a focal cognitive disorder displayed as amnesia. So they just have an inability to learn and recall new information, or they forget those recent events that have happened. So what is an intellectual disability? So if I tell you that a patient has an intellectual disability, what would that be? They could have Asperger's. Okay, what else? Autism, okay? So could intellectual and learning disabilities overlap? Could a patient have both of these? Right, they could, but they don't have to. They can have one without the other. So if my patient has an intellectual disability, it's going to be a lower than average IQ. So if a patient has an intellectual disability, it's going to be a lower than average IQ. And they lose some of the abilities to comprehend their social skills and how to perform ADLs. So they lose some ability to comprehend information, have social skills, and perform ADLs. With intellectual disabilities in comparison to the other ones, we'll notice this at a younger age. So we'll notice this typically before age 18. A lot of times when the child starts getting into the school setting, that's when the educators and such will notice that that child's not functioning at their expected level. It does have a range. It can be anywhere from mild to profound, depending on the patient. A learning disability is going to be difficulty processing information. So difficulty processing information. So intellectual disability affects their social skills and ability to perform ADLs, and in learning disability is a difficulty processing information. So that means that if I give this I say student because they're usually younger, but if I give them all math problems, some are able to comprehend and perform at one level where the other one would have a learning disability if they don't meet that expected benchmark. You can give them that information, but they just don't have the ability to always process that information at the expected level. That also could be mild to profound depending on the patient or the individual. So sometimes we'll have someone that they know their letters, they know their sounds, but they have difficulty putting it together to form words. Well, that's a learning disability in a pretty mild form. It can be corrected. Let's say if I have a baby that had fetal alcohol syndrome and they have severe disabilities, they may never learn those letters and sounds and how to perform words. Okay, so it really depends on what they've been exposed to and what caused it. But intellectual is going to affect more social skills and ADLs, whereas learning is going to affect their ability to read, write, draw, things like that. All those things that we would expect them to learn in school as far as the education, that's going to be their learning disability. So when we look at consequences of cognitive impairment, just in general, no one specific cognitive impairment or other, why are these individuals at an increased risk? Okay. Why are these individuals at an increased risk for injury? So if I got that granny that's in the nursing home, she has dementia, why is she at an increased risk for injury? For falls and environmental injuries. Right, just not knowing safety. So would I be concerned that she would be up at the hand sanitizer messing with it and thinking that it's juice and wanting to consume it? Because that ability to know that it's a danger has gone away. Would this be a patient that I would want to have SCD hoses on? Why not? Because you'll tell her at 5 o'clock, don't get up. If you need me, call me. And at 5:01, what is she doing? I gotta go to the bathroom. They don't recognize the danger associated with their actions. It can complicate disease management. Have any of y'all ever worked with someone that has dementia or Alzheimer's? Some people have worked in those specialized units. Do those patients like to take their medicines? Mm-hmm. They don't. You tell them 3 or 4 times to take them. What do? Okay, I'll take it. Yeah, forget to take it, or they sometimes they'll take it, and then what they'll do back at you? Spit it back at you because you're not the right person to give it to. You don't look alike. You look like somebody from a past life, and I'm just not trusting you to give me these medicines. So it complicates disease management as far as them being able to be compliant. A lot of times it's not an intentional non-compliance, but because they have that cognitive impairment, they don't have that ability to be compliant. They have a decreased functional ability, including capacity for independent living and also normal social interactions. If you have someone that has dementia or an impaired cognitive status, let's say if the patient has Down syndrome, would that patient always be able to live independently safely? No. Are there some group homes and such in place? Absolutely. But some of them don't have the ability to ever be able to be in their own homes safely, especially for extended periods of time. Of course, increased need for assistive services such as social services. Some of them can't drive, so they have appointments. They have to depend on different companies and such to come pick them up and take them. What about financial hardship and caregiver burden? How does that come into play when someone has a cognitive impairment? Let's say if you have someone, right now I say this, we have a physician whose wife has pretty bad dementia at a young age, like in her 50s at a young age. Is he able to freely come and go? No, because if he wants to, now that partner, that spouse is in a position where she's not able to care for herself, so does that not become a burden to the one that's taking care of them? Does it not become something that they have to think about and tend to? So it becomes a burden on the person that's caring for them. Now, if they're in a long-term care facility, that's different because we have providers around the clock. But otherwise, if they're in a home setting, it does become cumbersome to have to find care when you have to go run errands, go to work, things like that. And then also it's a cost associated with it. Medicaid waivers don't pay for everything, so they have to come up with the financial means to also have that provided there. So when we look at risk factors, we know that elderly individuals are at highest risk for cognitive impairment, but there are no differences based on race, ethnicity, and gender. So it doesn't matter what race the patient identifies as, doesn't matter any of that. Anyone can be at risk for a cognitive impairment. What male, female, doesn't matter. When we look at risk factors specific to women, we look at poor health status. What role do ladies usually take on in the home setting? The caregiver. So do they always tend to themselves? They don't always get their checkups, don't always take their medicines because they're so busy, typically, not always, but typically tending to the needs of others. Sometimes we have women who are in a dependent situation. So they don't have, depending on their culture and stuff, they don't have the ability to make those decisions. They have to depend on a spouse to be able to make decisions for them. Sometimes there's a lack of social support, and then we talk about insomnia, sleep deprivation, that can lead to it also, because a lot of times they're in those caregiver roles. When we look at our male patients specifically, history of stroke, diabetes, what does diabetes do to the vessels? It eats away at it. It damages the vessels. So if my vessels are damaged, do I have adequate perfusion? Do I have adequate flow of blood and O2? We don't. It does not happen. So we see that more so in our male patients. When we look at individual risk factors, we know that personal behaviors, substance abuse, participation in high-risk activities, and accidental injuries. What gender of patients would typically have the participation in high-risk activities?
Adolescents. You said gender or age?
Gender.
Gender. Boys.
Boys. Our male patients tend to have more participation in high-risk activities. And so driving without a seatbelt, driving over the speed limit, thinking it's okay to jump off things they shouldn't, even be climbing on. What does that put that individual at risk for?
Traumatic brain injury.
Traumatic brain injury. So it can cause, anytime they have that jolt or injury to the head, it can cause that traumatic brain injury. Environmental exposure, sometimes that's like toxic substances and chemicals. It could be from their work environment, depending on what kind of work they do for a living. We don't see it as much, but it still is a concern. Lead poisoning, especially some older homes that have lead paint in them, and kids get into lead paint and pick away at it and eat it. That can lead to a cognitive impairment in that individual. When we look at congenital factors or genetic conditions, the status of the mom when she's carrying that baby. So if I have a mom that suffers from alcoholism or drug abuse, could that affect that infant or in utero? Absolutely. And then birth injuries, when we look at cerebral palsy and such, that can lead to cognitive impairment also. Research has shown that individuals who have a physical disability have a quicker decline in their cognitive status. So let's say if I'm wheelchair bound, I have to wait on someone to take me from one place to the other, to bring me something to eat, to help me toilet, to help me bathe, things like that. Those individuals that have that physical disability have been shown to have a quicker decline in their cognitive status. And then we look at health-related conditions, acute and or chronic treatments. We know that any issues with fluid and electrolyte imbalance, infections, fever, pain. Pain can temporarily alter someone's cognitive status. What happens if the patient's blood glucose drops? Are they awake, alert, and oriented? Absolutely not. Most patients, when that blood sugar or blood glucose drops, what happens? What do they look like then? Huh? Right, yeah, like they're halfway comatose. You're talking to them and they're just kind of sitting there. The speech becomes slurred and things like that. A quick fix, but nonetheless, it causes that temporary disturbance. Patients who've had a CVA or stroke, do they always, at the back end, once everything's resolved, do they always end up with their maximum cognitive ability? No. Sometimes it's physical, but sometimes it affects their cognitive status. And then, of course, medications. Y'all just wrapped up some psych pharmacology. Psych meds are one of the more common ones to alter a patient's cognitive status, but also chemotherapy agents have been shown to alter it also. High-dose pain medicine. So if I'm giving that patient a lot of Dilaudid, morphine, Demerol, that can cause a temporary cognitive impairment. So when I look at history and examination, if I'm worried about this patient having cognitive impairment, what are some things I want to look for, ask about, assess for in that patient? What are some questions I want to ask that patient? Huh? Name, date of birth. Can you just recall who you are? What else would I want to know along with name and date of birth? What day it is, and where you are. Are you at least oriented times 3 the person, place, and time? Can you tell me who you are, what today is, and where you are, and why you're here? Do you know the situation? What else? What recent things going on? What I want to know, or recent changes going on? What I want to be aware of. Any change in medications? So let's say if a physician's upped or decreased a dose of that patient's medication, so I want to know if any recent med changes. Also, what medications is the patient taking? Let's say if this patient's recently been started on something for schizophrenia or bipolar disorder. I want to be aware of that because we know those psychoactive meds can alter a patient's cognitive status. What about diseases or recent infections? Yeah, I want to be aware of that. Have you had a recent infection? Because we know that can alter it also, especially if we get into some meningitis, hydrocephalus, and things like that. When I look at their general appearance, I want to look at the patient's posture, their body movements, their hygiene. Are they dressed appropriately? Sometimes it'll be 100 degrees outside, and I see these little old people. Sometimes they wear long sleeves because they're cold. But sometimes people do it because they don't recognize that it's hot outside. Like their cognitive status does not line up with knowing what the weather is, what season we're in, and things like that. So I want to know if they're dressed appropriately for the environment and also for the season that we're in. As far as behavior, I want to observe their facial expressions, their speech, the effort and rate of their speech. What acute speech changes would I want to be aware of?
Slurring.
Any slurring of speech?
Garbled speech.
Any garbled speech?
Repetitive.
Huh?
Repetitive.
Repetitive speech. Maybe they don't realize they told me 3 times that they forgot to lock the door this morning. Maybe, because they don't recall that recent, information. Is the speech appropriate for the situation? Recently, I had this lady come into the ER, and she was 86, I believe, and we were talking. She could tell me who she was, where she was at, what month it was, what was going on, and then she started saying, well, I got 2 little kids at home, and they stayed with my neighbor last night when I came in, and I really need to get back to them. Well, are these like your great grandchildren? No, those are my boys. I birthed those boys. Those are mine. At that point, I'm like, yep, we got some memory issues going on. But if I just ask her just who you are, where you're at, the date, things like that, we would have been fine. But the longer that conversation went on, I began to notice she spoke very clearly. I could understand everything she was saying, but it was not appropriate for what we were at, what was going on. So she was recalling events that had happened 60 years ago because her kids were much older than what she could remember them being. Assessment of cognitive function. As nurses, we won't always necessarily be, we won't be responsible for the testing of cognitive function. We'll be responsible for the assessment. So if we notice any acute changes, reporting it to the provider and things like that. But there is actual testing like MMSEs and such that can be done by other professionals to actually see where that patient lies, whether they're mild, moderate, severe, or profound cognitive impairment. Other diagnostic tests that we want to do, lab tests. There's no one specific lab test that can diagnose a cognitive impairment, but maybe it can help rule out some other things that could be going on with this patient. Then, of course, we can do MRIs, CTs, PET scans, and such to detect any changes within the brain itself. So what are some things that we could tell our patients to prevent any changes in their cognitive status?
Promoting a healthy lifestyle, optimal nutrition, exercise, activity, and medical.
So living a healthy lifestyle, so eat your fruits and vegetables, drink alcohol in moderation, lots of water, because we know dehydration can cause a temporary decline. Avoid drug abuse. There really is no moderation in drug abuse. Avoid drug abuse. What about pregnancies? Let's say if I have a young lady that's wanting to become pregnant, when would her lifestyle changes start? The day she gets pregnant or the time leading up to it? The time leading up to it, because if there's anything going on with the body going into the pregnancy, that too could affect that infant in utero. Genetic counseling may be needed for some individuals, especially if we think about the risk of certain genetic disorders that can cause. Sometimes we get like PKU, where they can't break down amino acids, and that can cause some cognitive changes, Down syndrome, things like that. Secondary preventions, there be more screening measures that can be done. There's no specific test that is recommended. It really just depends on the individual, their history and genetics, and where they are, what age they're at in life, and their risk factors. So there's no one specific thing for secondary prevention. So with this content, when we come into it next Friday, we'll discuss traumatic brain injuries and Alzheimer's. Those will be the two major exemplars for the cognitive or cognition content, okay? So traumatic brain injuries and Alzheimer's will be our two major exemplars for that, okay?